Good afternoon, everybody. We're going to go ahead and get started with our Panhandle Health District meeting. Today's date is April 9, 2025. The time is 3 p.m. In attendance are Commissioners Eberline, Duncan, and Matari. I'm going to call this meeting to order. Are there any changes to the agenda? Hearing none. Public comment. Hearing none. Let's move to our first item. Panhandle Health District Strategic Planning Meeting, and we have the chair of the board, Dr. Thomas Fletcher, here.
Well, thank you for this audience. Actually, this whole idea started in this room with 2 out of the 3 of you. So
you got to make sure the light's green. There you go.
To thank you for this. In fact, it was your recommendation that we actually delay the meeting until May so that the legislative session would be over and that we could give the opportunity for our legislative friends to attend the meeting. And another topic that was discussed in this room with you, and I'd like to address it again on this occasion, and that is the arrangement of this room. And I've given it some thought, and I've also caucused the idea with other commissioners. It's the way I see this workshop. I'm calling it a workshop now instead of a strategic planning meeting because, to be quite honest with you, the scope of the meeting has narrowed down. And I'll get to that in a minute, but I want to sort of first address some of the practicalities, such as how do we arrange the room. I'm thinking, and this is subject to editorial review, no pride of ownership here. I'm thinking if there's a way in which we can have an assortment of tables and that we group Panhandle Health board members with their respective commissioners. So we'll have 5 groupings. Go ahead.
Fletcher, could I have you just step back for a second? Maybe the other commissioners know what you're talking about, but I'm not quite following with you. Why are we talking about rearranging the room just yet? Is this for a upcoming meeting?
Okay, I apologize. I thank you. Yes, May 10th.
Okay.
9 in the morning, strategic planning meeting. So, okay, thank you for saying that. I'll back up. Let's talk about the meeting, if you will, and what its intended purpose is. So, and I apologize for jumping the gun. My thinking is not, I have to remind myself that I'm hitting a new set of people each time. Thank you. I think public health, certainly in this country, maybe the whole world, is at a crossroads. The whole COVID experience was a form of shock treatment. A lot of things were done incorrectly. And if we are to believe that public health actually has a purpose in human civilization, which I do, I think it has a purpose, then it is incumbent upon us, those who are in public health, to do something to restore the trust in public health and the efficacy of public health. And I think both of those conditions are, shall we say, injured. Not fatally, but they're not as, public health is not as robust as it could be or should be. Okay. So I think now is a good time for Panhandle Health to engage in an introspective exercise. What are we doing? Why are we doing it? How are we doing it? Could we do it differently? And thus, if you will, the rationale for this meeting is to gather together the commissioners, and we take our orders from you guys. I mean, I work at your behest. We set policy at your behest. The budget is structured by you, and this is all by statute, and I think it's appropriate. So if you're going to have a meeting wherein you engage in some measure of reflection on where you want to go moving forward, then you guys have to be front and center. We take, again, we take our marching orders from the 15 commissioners of the 5 participating counties. And the proposal is to have this exercise on the morning of Saturday, May the 10th. And it's going to be in this room. And the principal participants of the meeting will be the 15 commissioners, and then the board members of Panhandle Health, and then the public. Are there any questions, Commissioner
Matari, just like the game, but with an M in front of it.
Did I answer your question?
Yes.
Do you have other questions as it relates?
No, I'm just trying to understand. And plus, we have people who watch these videos of these meetings at home, and so it gives them some context as to what you're talking about.
I got it. If you were to, if you took the entire portfolio of what Panhandle Health does, so that would include, the septic permits and the food handling license and so on. As I've gone around and caucused with not only citizenry but other commissioners, the consensus I get is that to engage in, if you will, a strategic planning exercise on the entire portfolio is probably too much. So instead, we're going to limit the discussion just to the clinical services. Now, that is subject to editorial review. If there are any of you who would prefer to have a discussion on solid waste disposal or other topics, I'm certainly open to that. Some of the reason why we cannot, or not cannot, but it wouldn't be as useful to engage in an introspective exercise on a topic like solid waste or septic permits is that essentially Panhandle Health and all of the health districts are subcontracted by the Department of Environmental Quality. It's really, these are statutes and rules that are created above us, and we've just been contracted to execute. So it's not like we're in a position to create our own policy. We don't, in fact. Ditto with food handling. Those rules, in fact, even supersede Boise. They go to the USDA. So we're not, while we could engage in a exercise of are we doing food handling correctly, it doesn't really matter. We're just subcontracted to carry out existing statute. So the only aspect of the portfolio of business that Panhandle Health executes that is, if you will, within our domain to actually do something about are clinical services. Does that make sense? Mm-hmm. Okay, so therefore it's a workshop on clinical services. And so you say, well, why are we having this? Well, in the capacity of being the chairman, I've actually taken the opportunity to do some secret shopping. I've gone to our clinics, not announcing who I was or even why I was there or anything, just kind of go. Back when I practiced medicine, I was in a group, we had 20 clinics. I happened to have been the medical director of that group, and I would frequently visit our clinics for the express purpose of, well, what does it look like from the perspective of a patient? I mean, is the facility clean? Are the employees friendly? Are patients moving effortlessly? Do you have patients? Are the patients behaving in a normal fashion? So I was actually doing some secret shopping, if you will, from the point of view of intelligence gathering. And what I notice is that the Panhandle Health clinics are empty. Now, this is a very unscientific assay. I mean, I just randomly showed up at random times. So I don't have real data. With a little bit of luck, Eric Kattner is going to generate some data for us for purposes of this exercise that we're going to have on May 10th. Now, you might ask yourself, well, why do you not have patients? I don't know. We can propose a number of hypotheses. Maybe people don't know that there are clinical services available at Panhandle Health clinics. It's just a matter of people not knowing. That's a possibility. Or it may, the absence of people there may be a reflection of a loss in trust. I don't know. Maybe the hours are wrong. I don't know. Maybe the type of medicine that is provided is not in keeping with the type of medicine that a lot of our citizens are looking for. That is to say, you have a dominant model of allopathic medicine, and maybe there are more people in our citizenry who are interested in integrative medicine. I don't know. These are all hypotheses. I'm just throwing them out. Maybe with the Medicaid expansion 2 years ago and in the infusion of $800 million, people can now take their Medicaid card and go get boutique medicine wherever they want. They no longer need to access health care from a public clinic. And maybe there's a stigma going to a public clinic and they'd rather go to a private clinic, if you will. But then we know that the pocketbook, the kitty of Medicaid, is now in flux. And as a matter of fact, Seth Griggs, who will be facilitating this meeting, I've asked him to give us an update on the outcome of the Jordan Redmond and other legislative efforts that took place in the session that just closed last week. So there's some new information that will have a bearing on the behavior of the citizenry. So from my perspective, what's on the table in this introspective exercise is the function of our clinics, of the Panhandle Health clinics. Are we getting a reasonable dollar value for providing the services that we do? Should we do something different? Should we close them? There's one Health District 2, that's actually closed all their clinics. I know from personal communications with one of the board members in District 4, Vicki Purdy, some of you may know her, she would like to close the clinics in District 4. And I also know from sort of caucusing with some of my cohorts, there are other clinics that are thinking of shutting down clinical services. And if they're not used, why have them? I mean, it's sort of a budgetary question writ large. I'm not suggesting that be the case, but if we have an underutilized service and it's an expensive component of the budget, then maybe we need to think about what we're doing. That's the rationale of this exercise.
Okay. I can tell you just my initial thoughts, but let me first ask my contemporaries here if you have any questions or comments. I would prefer that, one, all decisions be driven by data and not anecdotal stories, and you acknowledge that. I have no idea, why people weren't there when you showed up on those days, but I have to assume that the data would support that there are people who do show up over the course of a month or 6 months or what have you, and we could look at that. The other thing is that, at least me personally, I try not to get involved with making decisions about things that I don't know really well. So health, public health, which you and I have talked about a little bit, that's something that you know a lot better. So from a strategic perspective, it seems it would be more productive to try to understand what the problems are, identify the problems, the causes of the problems, and then saying, okay, here's what we've discovered, and we have some options for which way we can go. It turns out that we pay all this money for these clinics, and they only serve 20 people a month. Well, that tells us that, we're probably not, we're not getting a good return on our investment. Then maybe some information. I have no doubt that what happened during COVID blemished the reputation of Panhandle Health. I mean, we've talked about that with the mask mandate. A lot of people were very troubled by that. And so maybe some of their cachet went down as a result of that. I don't know. But my hope is that if there's going to be decisions for us to make, it's going to be data-driven, and it's going to be providing some recommendations by the people who are in this business and asking us what we think, as opposed to asking me what I think now as an example. And I'm going to go, I don't know, because I don't know the business of public health like you do and the folks at Panhandle Health.
So it's my intention to start the morning out with 3 lectures. The first will be from Eric Kattner, who is going to summarize the activity in the clinics over the past 10 years. So we're going to go back to a period of time pre-COVID so that we can get a baseline of what things were like pre-COVID. Then we can see what COVID did, and then we can come to the current era. So we're going to actually try to provide you, and as a matter of fact, on Thursday of next week's board meeting, Eric is supposed to have generated all of this analysis. As soon as I see a hard copy of that analysis, I will make sure you get that information in hand. So you should have it several weeks before the meeting. So that's that. Then the next bucket of data ostensibly should come from Seth Grigg, who's going to tell us how much money we have to spend. What are the ramifications of the most recent Medicaid legislation that has occurred, which is going to have a direct bearing on how much money we have to spend. Now, some of the issue of what money we have to spend is an absolute unknown. We have a totally new set of personalities and ideologies in the federal health agencies, NIH, FDA, CDC, et cetera. And the ultimate ramifications of this new set of ideology is an unknown. I think about the only thing we can predict is that it's going to change. But how it changes, I don't know. I mean, make America healthy again will have fiscal impact. We do the best we can. I suppose one could make an argument, why don't we hold this whole exercise off for a year until we find out what the feds are going to do? That actually is a fairly legitimate stance to take. It's premature at this moment to have this conversation. And I'd have a hard time arguing strongly against you, or at least against that point. It's not you. It's not personal.
Of course.
Yeah, no, it's not. I get that, by the way. And then the third lecture is actually going to be from me. And you've sort of heard a preview of that lecture. I'm going to give kind of a review of what public health means, essentially going from the Bronze Age to the current era, with, in particular, emphasis on the differentiation between public health and private health. And I think that's a salient distinction to make because in some people's thinking, and Brad Little signed it into law less than a week ago, perhaps public health ventured too far into private health. And there is a rebound effect. And we feel it. We sense it every day. We read it. We know that this is not just a figment of our imagination. So the recalibration of our clinical services in some measure could be a reflection of the recalibration of what we mean by public health. Maybe public health has been doing too much private health. And you were privy to some of my comments on that before, but I'm going to flush it out and give more data. So those 3 lectures will head off the meeting, and I'm hoping will provide some of the substrate that you're yearning for so that you can have a more meaningful conversation. Does that answer your question?
Well, I mean, it wasn't so much questions as much as it was just, if we're to make a decision, this is how I would like to make a decision.
Right.
I agree with you at the national level because there's so much uncertainty to get together, and then I don't think we could make an informed decision with that much uncertainty. I mean, like yourself, I'd love to see the interior of a grocery store worked out from a Make America Healthy Again, and focus on that.
One of my favorites, by the way.
Yes, because it's the exterior where you want to shop, right? The perimeter, if you will.
You should remember that.
Yeah, well, it's something I've heard many times over the years. So, as the perimeter is the best place to shop.
Yeah.
So, with that said, it's I'm going to go with your recommendation. Of what you think we should be doing, when we should be looking at this stuff, and what you think, because that's why we have you on the board. I mean, I have all the confidence in the world that you're looking at this from a public health perspective. You have your finger on the pulse. I mean, you obviously act and behave like a business owner, which is why you're doing the secret shopper stuff, right? to make sure that the entity that you are overseeing is doing what it's supposed to be doing. And so I commend you for that, because so few people actually do that.
Well, and I appreciate the vote of confidence. And you will hear my opinions. But I don't want my opinions to be in isolation. I want them to be in the context of consensus. I don't want to say, look, here's what needs to happen, and you go, okay, thank you, Dr. Fletcher. I want us to all come to the table and have an adult conversation. So I actually cherish your opinion and your feedback. Mm-hmm. I mean, I'm looking for it. Trust me, you're going to hear from me.
Yeah, well, I understand.
Commissioner Duncan knows this.
Does anyone up here?
I surmise it too very well.
Yeah. Does anyone up here want to speak at all? Because I don't want this to, any comments or thoughts or.
I'm gonna bring this up on Friday to the IAC District 1 body, and just kind of get some thoughts on that. My initial thought is let's have it, because I think there's good conversations that can be had about pivoting. Pivoting meaning, if we know where we're at right now today with clinical services, how easy is it going to be to implement some of the Make America Healthy stuff when it does come down the line, or if the Medicaid expansion, that's the wrong word, Medicaid sideboards cause a shift back to public health. So I think it's worth having the conversation. If it's put off, I'm not sure that there'd be a whole bunch of harm, but I think there's still value in having it now. But again, I will talk to everybody on Friday and see if we can get some consensus amongst the commissioners Friday to see what maybe they're looking for and what they hope to get out of the workshop. Does that make sense?
Makes plenty of sense. And let me add to that. My intention of the exercise is not to have an action item. I'm not looking for an answer or a direction. It may be, well, to be honest with you, it's scenario planning. What if this happens? What if this happens? What indicators are we looking for? I mean, here's one example. Should we continue? This is an easy one. Should the health district still engage in the vaccine program? What's the future of the vaccine program? What are the liabilities of the vaccine program? How much money are we getting from the vaccine program? I mean, there's some real sort of practical questions there. There will be changes coming down the pike on the CDC childhood vaccine program. I can assure you of that. What they will be exactly, I don't know, but they're coming. Do we want to anticipate those changes? Do we want to get in front of those changes? Do we want to prepare ourselves for those changes? I mean, that would just be one example. How about WIC, women imaging, the women, infant, children? I mean, a strong argument can be made that the major baby formula manufacturers are providing to our infants, our young children, a substance that is not optimally healthy. This is going to come out. Jay Bhattacharya, I mean, the reality is there. It's a matter of taking the lid off of the censorship. I mean, Fruit Loops aren't healthy either. What's really interesting, is the products that we give our kids, you can't find in the European Union. I mean, so there will be things coming along. And so if we have a USDA program, the WIC, which is a big component of what Panhandle Health does, what's going to be the ramification when, gee, what you've been giving your kids is not healthy?
I'm just curious, are the health districts precluded from giving out information on alternatives that could be healthier?
Well, sir, isn't that a great question? Will you hold that question and ask that on May 10th?
Well, I'm just curious because if they're not precluded, then my question is, why are we not looking at developing those programs?
How politically incorrect can I be?
Well, keep it mild.
You're on video.
Oh, well, actually, I'm not afraid of saying anything. I don't know what your political I don't know. I have nothing to lose. I'm retired and I'm not a political creature, although I am giving thought to running against Mark Sauter. But that's a different matter. Statutorily, we're not prevented. But you'd have to have a board willing to go out on a limb. And right now, we don't have a board that's willing to go out on a limb any further than the strict recommendations of the CDC as it relates to any of our policies. So, are we prohibited? No. As a matter of fact, as you may know, curiously enough, the health districts actually enjoy a fair amount of statutory liberty. We are not underneath the Department of Health and Welfare in Boise. We're separate from them. And the only, if you will, strings attached are actually from you through the legislature. Otherwise, we're sort of free to do what we want. So, are we prohibited? No. As a practical matter, do you have board members who are willing to execute on some of the measures that you might imagine? No, you don't have a board that's willing to do that.
In this district?
In this district.
Okay.
That's correct. I think I already alluded to other districts doing other things. That's correct.
Okay. Okay.
Which is actually, that's a very cogent point you just made. Because of this statutory independence, the 7 health districts can more or less operate independently. Mm-hmm. Curiously enough. And I guess that's how the legislators intended it way back in 1971. Their idea was, have a health district for each region of the state that could kind of do what is in the best interest of that region. I don't know that they thought quite so far into the 21st century and could conjure the kind of dilemmas we have today.
You probably treat them too well.
I don't know. Did I answer your question?
Yes. What else do you have for us?
Well, I would like to discuss now what I started out wanting to discuss, and I really do apologize for jumping the gun. That was very rude of me. There are some practicalities. Just the layout of the room, how long the meeting should last, how people, where they sit, and where Seth Griggs going to be, and so on. And here are my thoughts, and I'm fully open. It will be in this space, I trust. So what I would propose is that we have some tables set up in a horseshoe fashion, and that we have the commissioners and their board members sitting more or less together and named as such. So everyone is designated. The public will be in seats such as this, and so the commissioners and board members will face the public. Seth will be basically where I'm at. So he's going to have to talk in a circle, like some, circus barker. But he's a very clever man. I have all the faith in the world in him. And I think we're, frankly, quite fortunate to have him willing to facilitate this exercise. He's a real professional. I would propose, okay, so that's how I would lay the room out. Then I would propose that we start at 9 a.m. and that it just be a morning session, not all the way through the day, with, if you will, a soft endpoint. So the beginning point will be hard, and I would propose that we start off with the 3 lectures that I just outlined. After that, we will have the public submit items that they would like to talk about, but in writing, and Seth or somebody will rifle through those, collate them, because we're going to get 500 of them having to do with chemtrails, and we can reduce that to just 1. And then announce what those topics are. Then we migrate into an exercise of addressing the mission statement of Panhandle Health. Maybe spend 20 minutes on that. Look at the mission statement as it currently exists. See if we're happy with that, if we want to change it, whatever. And then we go into the actual exercise itself of discussing the clinical services. And you will have been given some information beforehand. Then questions can, then we start going. And Seth will say, all right, we've got the following program. What are the pros and cons of this program? I mean, I'm going to leave it up to him to micromanage that component of the conversation. I would not have an action item. I would not expect from this exercise that we have a specific direction. It's simply to brainstorm, scenario planning, think about what the topics are, and then perhaps we can, on a one-on-one basis, or perhaps have the exercise again a year later after we have a better idea of what MAHA will mean and what funding is available and what directions that Bhattacharya and Kennedy and others are taking us. And there will be a direction, and I think we should clearly follow the money. I mean, if there's money to be had in a certain area, go for it. I mean, that would be silly not to. And then follow up after some period of time, and then open it back up to the public, but this time the public gets to speak. So up until this point, the interface of the public has been written questions or topics so that we can actually do some business. But then I think it would be worthwhile to let people speak, let them actually have that cathartic effect. I think there's value in that. But that would be at the tail end. That's why I say the end of the meeting would be soft. I mean, I don't know if there are 100 people lined up. Well, then I don't know. I don't know how to bring an end to people like that. But I'm sure Seth will figure it out.
What do the other commissioners have to say about this format?
They like it. In fact, it is an amalgam of a lot of other ideas. Well, I mean, there's one commissioner who said that, well, 2 commissioners, I'm not going to say any names, who don't even think that the commissioners should speak.
Well, they're welcome not to. Does anyone up here have any comments or thoughts on this?
I stated mine.
I was going to suggest go ahead and put it all in writing. Sketch out how you want the room to be. We'll have our folks put it together.
Okay.
And you will probably end up being the ringmaster along with Seth.
I might be, and I'm certainly willing to do that. I mean, certainly when it comes to one-off questions, well, you heard me.
I know.
Yeah,
Just give us a list of what you want to talk about so we can kind of lay it out in a public noticed meeting.
yeah. No, I'm there.
Does it have to be on a Saturday? Can it be on a weekday? Or is this already scheduled?
It's already scheduled.
Well,
Already
I scheduled with Seth in October of last year.
Okay, well then it's cast.
I
The
mean,
die is cast.
And I've got confirmation from him, he's coming.
Okay.
So, and he's such a plum, I would hate to, I mean, we could still do it without him, but.
It's just a question, that's
Yeah.
all.
Well, now, I'm going to throw this one a little bit back on you because it was the decision to make it on that day with you guys. You might not remember.
I think, oh yeah, it's been a while, but I think part of the issue was if we wanted maximum attendance from public plus legislators and everything, that was kind of the best thing to do. Because trust me, I tried very hard to get it off of a Saturday.
Yeah, it's fine. I mean, it's just a question, that's all.
Yeah.
It was the Kootenai County Board of Commissioners you were the very first people I spoke to in this room, and I was pretty much standing right where I'm standing. So.
We have an email.
And I wasn't even sitting in
And
this.
you weren't even here. Your
That's right.
predecessor was here. So I can't blame you. Yeah. Welcome to the trouble they generated. I don't know. I think even if it's scenario planning, I mean, there's so much going on. I think it's useful to kind of figure out what are we doing. And I mean, we can always just do status quo. Okay, we do nothing.
My concern with that is that we're overtaxing people if we're paying for, but not fully staffing or utilizing the clinical services. So I think that what I'm going to take away from this workshop is kind of my direction and funding for the next year, if that makes sense.
That's exactly what I wanted to do. I want you to be thinking about where you want the funding to go. Absolutely. Amen. And in a context in which to think about that funding. That's it.
All right. So you'll put everything together?
Yes,
We'll
sir.
get
Oh,
that-
one final caveat. I'm seeing a big smile over here. This may not happen. Because the board may not wish for it to, the Panhandle Health Board may not wish for it to proceed. So if it proceeds, then good, and if it doesn't, well, then it doesn't.
And you'll know April 17th.
I will know Thursday week, the 18th.
Okay, so the
I think that's
date.
no, it's not tomorrow, it's 8 days from now.
Right.
All right, well, just let us know then.
You will be the first because it's your room. Here's a question, again, kind of a practical question. It is your venue, it is your building, your room, whatever.
100%.
It belongs to the citizens of Kootenai County.
Yes, under
Belongs to the
our,
citizens of Kootenai County. Thank you, sir. So, as just a matter of decorum, it's strictly, you have a bunch of people coming in here. Who stands up and speaks first?
that depends on your agenda and how you have it laid out, and if Seth is going to be your MC doing that. So again, to Commissioner Matari's point, if you kind of reiterate this meeting and your thoughts on it, if the PhD board decides to go ahead with it, then they would okay the agenda.
Well, they will, but I'm now, okay, let's assume we're going to go with it.
Mm-hmm.
It seems to me reasonably speaking, they're one of two people that should stand up first. It's either Bruce or me.
Well,
It's your building, your venue, and you could say, welcome everyone to our home. We're glad you could come. I'm now going to turn it over. Or I just stand up.
probably because it's a public meeting,
Uh-huh.
I would just open it
Thank you. Thank you for saying
and then just close it.
Great. That's what I was wanting. I wanted someone official to actually officially open it. And then you can say, now let's hear from Panhandle Health, and turn it over to me. And then I'll say some things, turn it over to Seth, who then takes over. That's how I see it also.
Yep. And each county will actually have to have their own clerk if they have a quorum. Mm-hmm. So.
And I'm going to leave it to the other commissioners. Because it's an open meeting, does every board of commissioners bring their own scribe?
Mm-hmm. Usually, yes.
Okay, well then I'll leave that up to them. They must know their own rules.
Yeah, and I'll mention that again on this coming Friday.
Right. Okay, that's fine. Oh, we didn't talk about, well, we talked about the public. So I said in the beginning, we'll take questions written so that we can have time management and content management. But then at the end, they get a chance to speak. 3 minutes, you know, the usual format. They sign in, whatever. You're okay with that? Well, I guess there's two questions. You're okay with letting people speak?
This is your workshop, and if that's part of the public engagement, then that would be your decision.
Okay, well, that's what I want. I want the public to speak. So the next question is, are we going to Zoom this?
So we have to have a discussion. I guess we can have it right now. Because Jonathan, what are you doing May 10th?
I'll be right here, Commissioner.
Okay. So likely we will be able to have it on YouTube, but it would not be Zoomed. So people
Okay,
could
that's
watch.
fine. Well, but internet access. Okay, so the next question, and I do have an opinion here, but I want your opinion first. Will people who are YouTubing in be able to ask questions, or would the people permitted to ask questions only be those who physically show up?
We have a call-in number, so people can call in and ask a question.
If that's, again, this is your workshop, so if you would like the opportunity to have people call in, we are already set up for that.
My instincts are I'm welcome to have public ask questions, but they need to be here and not call in. That's my intuition. I'll leave that up to Seth, though. If Seth feels otherwise, I'll let him make that call.
Yeah, I would suggest that you consider calling in, just because we're dealing with 5 different counties. So people may not be able to get here. That way they can watch it from their home, not have to travel down here. If they have a question, they can call in, because it's a significant region you're talking about.
That's a valid point. That is a valid point. Even though the trade-off is you lose control, you might have a whole bunch of people calling in, but this is what we signed up for.
Well, I think we have a way to mute them and
I won't
keep
leave
control.
before you do, I can tell you that.
Well,
Are you going to close the meeting also?
well, yes.
Yes. Okay. We're in this together.
Be careful what you wish for, huh?
Well, like I said, it's a hard start point, but a soft end point. I don't know how long people are going to want to talk. There's a lot of pent-up frustration, I can tell you that. You know this. You live it. This is your world.
What else you got for us, Dr. Fletcher?
That's it.
Okay.
Any questions, comments, thoughts? All right. Well, it sounds like you have direction.
Thank you.
Next up, public comment. Would anyone like to speak? All right. 3:44, meeting adjourned.